Morning class. Today we're going to talk about cleft lip and palate among our pediatric population. These podcasts are designed to help reiterate some key points related to these topics that are included within your ATI system disorder module templates. So we're going to start with cleft lip and palate. So the cleft lip and palate is a congenital defect that occurs among newborn babies. It does occur very early in gestation, as you can see during the first few weeks of the first trimester there. That's when this develops in the fetus. It can be both cleft lip and palate, or it can be either one. And you can see from the pictures there examples of a complete palate and a lip disorder. So you can see listed here some risk factors related to developing this condition. It is more common among certain ethnicities. Native Americans and Asians can depend on the age of the mother. There are some environmental things that can be occurring during pregnancy that contribute, such as the intake of alcohol, some of those medications listed, etc. So this can be diagnosed prenatally via an ultrasound. And of course, with other defects as well, the earlier that we know about it, the better plan we can have for when that baby is born to repair it. So as you can imagine, dealing with the mouth, one of the biggest issues for these babies is feeding related. Obviously, prior to surgery, they have very poor feeding, difficulty sucking, which we're going to talk about. But as we all know, feeding is vital to a newborn baby, as well as all the other oral developmental things that come later down the road with speech and oral development, etc. So this is really the meat and potatoes of what you need to know. So as a nurse, prenatally and preoperatively, these babies can get repaired once they weigh around 10 pounds. So this does usually occur between 2 to 3 months for the lip. And then for the palate, they have to be a bit older. As you can see, they're 6 to 24 months. So important to know, feeding is a huge issue for these babies. Obviously, prior to surgery, they have to have special feeding methods. As you can see, it's an issue preoperatively and postoperatively. Once they do get repaired, though, things do improve. They have to have special nipples there, as you can see, the palate guards, etc. And, feeding is supposed to be a great bonding experience for baby and mother. So you can imagine this can provide some difficulty with bonding between the mother and her child. So very important when we talk about feeding and we talk about infants, and these infants with these special conditions, the position of the baby must be elevated at a 30-degree angle for sleeping and 45-degree angle for feeding, and this is to prevent aspiration. We're constantly monitoring these babies for their weight gain and feeding related issues. So once again, bonding as nursing, we want to really promote that to our parents and their young infant. So just encouraging them to hold the baby. They may feel a little standoffish with their child with this condition, but doing our best as nurses to promote that bonding relationship. Postoperatively, once again, very important to keep this baby's head of bed elevated at a 30-degree angle. We never want to put them on their face, so we never want to put them prone, because that can interfere with the surgical site there. Pain management is important postoperatively. Most of these babies being under 6 months do not get ibuprofen. That is a contraindication. And then initially postoperatively, we want to have them avoid sucking on a pacifier, nipple, bottle, etc., as to protect and preserve that surgical site. Nothing in the mouth initially postoperatively. Once again, we're going to encourage that bonding. So encourage mom or dad to hold that baby. That's a wonderful way to help soothe a infant, is to have somebody hold the baby and provide physical comfort to them. And then postoperatively, here we list some different devices that help with this process. So the Logan bow holds the cheeks together to help prevent that stress on the suture lines. The babies will often be in elbow immobilizers, and that's to avoid having them rub up against the surgical site. These do need removed every hour just to assess circulation, make sure they're not too tight, and to help promote mobility. We don't want these babies in these immobilizers constantly. As you can tell, that would help, that would, excuse me, that could have some skin breakdown and issues of that sort. So important to take them off, give them some air, let them breathe, and then put them back on. So here are some examples of what we just talked about, the Logan bow there and the elbow restraint on this little one. And then also caring for these post-op sites on the infant, we're going to use normal saline sterilely to clean those suture lines, keep them free of any debris to help prevent scarring, and then any antibiotic ointments that are ordered for your infant to apply them. And then, of course, we want to do our good pulmonary hygiene postoperatively to prevent them from having any complications, keeping them elevated at the 30-degree angle once again, turning them, holding them, monitoring for any signs of infection. And then when they are able to have anything by mouth, offering water to help cleanse the formula or breast milk out of the mouth. Other postoperative measures preventing infection. So we monitor temperature. If there's antibiotics ordered, we would administer them. And then we're monitoring their I's and O's and hydration status. And this, is a collaborative team approach. So we have our pediatrician, the plastic surgeon, oral surgeons, audiologists, orthodontists. So it's, as you can imagine, dealing with those mouth structures. You have a whole team of specialists who are involved in this infant's care. Later down the road, speech therapy, occupational therapy, we get them involved, of course, to have the best outcome for this baby with their oral development, and social work as well, to help with the parental needs of any home work-life issues that arise. And that is it for today on Cleft Lip and Palate.